Hereditary vitamin D resistant rickets, HVDRR. Refractory rickets, vitamin D dependent type 2A and B, due to mutations of the vitamin D receptor BDR and due to mutation of the H and RNPC gene, RNP basically vitamin D receptor elements, whatever. These two gene mutation gives rise to the severe sort of rickets, very refractory to treat, very difficult to treat. The when you say refractory rickets, at first stage you go for treating the normal rickets, the calcium, vitamin D, and if no response by pain and smaller tissues by 2 weeks, calcium phosphate correction by 3 weeks, and ALP reduction by 2 to 3 months, and X-ray clearance, if there were evidence of the X-ray changes by 1 month, and finally deformity correction by 2 years. If they are not been they are not been arrived, then you go for thinking the refractory rickets. Apart from that, these children are from the consanguineous parents, and they have your the receptor steroid, thyroid, the your retinoid receptor, they remain together, vitamin A and steroid and thyroid together, and thereby they have severe sorts of other presentations apart from the ricket. They have alopecia. When alopecia is total, the disease is quite severe, very difficult to treat, and alopecia partialis, little bit of response you can be there in this group. Apart from that, they might have the multiple miliaria, epidermal cyst, oligodontia, and your hypotonia, irritability, seizure, and your tetany. In late cases, they can have frontal brushing, rib case abnormalities, fracture, and the good amount of these cases are late diagnosed, and then they have higher mortality. You need to treat them by large doses of vitamin D, very high dose, 30 to 60 microgram per DL. You go in stepwise increasing the vitamin D and monitor it by calcium, PTH, and nephrocalcinosis by ultrasound, creatinine. So you may need to increase the dose by 100 times. So even IV calcium overnight infusion may be needed. Very difficult. It is very difficult to treat. So it needs to be addressed in that way.